Welcome back to Part 14 of our 150-part IPDRG Masterclass on Decode Healthcare with Harshal. Today, we're unpacking a really tricky, heavily audited area of clinical coding: poisoning, adverse effects, toxic effects, and underdosing. Now, before we get going, if you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal. Okay, looking at our agenda for today, we've got 1. Welcome and lesson recap. 2. Navigating the drug table. 3. Key clinical coding definitions. 4. Official code sequencing rules. 5. DRG impact and CDI queries. And finally, 6. Lesson summary and next teaser. Let's dive right into this explainer and conquer the heavy coding logic behind pharmacology documentation. All right, Section 1. Welcome and lesson recap. Let's quickly review the critical concepts we mastered in our last session. So in Part 13, we covered diabetes mellitus categories, E08 through E13. Remember, E10 for type 1 completely excludes the 11 for type 2. We spent a lot of time on how combination codes dictate the mandatory inclusion of complications, like CKD or neuropathy. For example, you'd use E11.22 for type 2 DM with CKD, while always remembering to code the specific CKD stage separately. Okay, we're going to apply that exact same level of precision to pharmacology today. Moving on to Section 2, Navigating the Drug Table. Let's look at the structure that governs how we code chemical and medicinal interactions.
When you actually open up the table of drugs and chemicals in your ICD-10-CM manual, you'll see it's organized to cleanly separate different clinical scenarios. That first column lists the substance name alphabetically, but the real magic happens in the subsequent columns. Notice how poisoning, whether it's accidental, intentional self-harm, assault, or undetermined, is kept distinctly separate from adverse effects and underdosing. Honestly, just understanding this layout is your very first step to accurate pharmacology coding.
Section 3. Key clinical coding definitions. Differentiating between a poisoning and an adverse effect is literally the biggest point of confusion for coders.
We have all been there, right? Staring at a chart, second-guessing the provider's intent. So let's break this down. The crucial distinction here comes down to intent and execution. An adverse effect happens when a drug is used completely correctly. It was prescribed right, administered right, but the patient still had an unexpected or bad reaction. A poisoning, on the other hand, is always caused by incorrect use.
And keep in mind, poisoning encompasses way more than just intentional self-harm. It includes giving the wrong dosage, taking a non-prescribed drug, improper administration routes, or even a medication given by mistake in a physician's office. But pay special attention to this. If a patient takes a correctly prescribed medication, but then mixes it with alcohol or illicit drugs like cocaine, heroin, or marijuana, boom! That instantly flips the classification from an adverse effect to a poisoning. No exceptions.
Then we have underdosing. This is exactly what it sounds like, where a patient independently reduces or skips their prescribed medication regimen. You'll often see this written in the chart as patient-reduced medications. And just as a vital side note, if the harm comes from a strictly non-medicinal substance, like carbon monoxide or petroleum or arsenic, we leave the drug table behind entirely. That's classified as a toxic effect.
All right, Section 4, Official Code Sequencing Rules. Now that we have the definitions down, let's see how this builds into our mandatory sequencing logic. These rules are absolutely non-negotiable for inpatient coders. Let's start with poisoning. If a patient is admitted for a poisoning, you must sequence the appropriate poisoning code, those T36 through T50 codes that indicate intent, as the principal diagnosis first. You then follow that with the manifestation code second. So if a patient comes in with cocaine-induced chest pain, the poisoning is the root cause of the admission. Therefore, you sequence the cocaine poisoning first and the chest pain second. Make sense?
But watch this, it is the exact opposite for an adverse effect. Because the drug was used correctly, you must sequence the condition or manifestation first. If a patient develops a severe drug-induced rash or tachycardia, the rash or the tachycardia is your principal diagnosis. That is followed by the specific drug T-code sequenced second to indicate the adverse effect. And for underdosing, you'd follow a similar logic. Sequence the medical condition being treated first, followed by the underdosing T-code and any code for non-compliance.
Also, because injury and poisoning codes live in Chapter 19, your job isn't done until you assign that mandatory 7th character extension to define the episode of care. It's A for the initial active treatment, D for a subsequent routine recovery encounter, and S for a sequela, which just means a late complication arising from a previous poisoning or condition.
Let's move to Section 5, DRG impact and CDI queries. Let's look at why getting these sequencing rules right matters so much for hospital reimbursement. Because the principal diagnosis is the condition established after study to be chiefly responsible for the admission, mixing up a poisoning and an adverse effect completely shifts the major diagnostic category, or MDC. A poisoning principal diagnosis drives the entire case into MDC 21 for poisoning and toxic effects. But an adverse effect manifestation, that drives it into a specific organ system MDC. So to put that into perspective, one single sequencing mistake here throws off the entire DRG grouping, completely altering the hospital's reimbursement.
And this is exactly why provider documentation is so critical. When the record is ambiguous or conflicting, it creates a documentation gap that directly impacts that DRG assignment and your quality metrics. This immediately triggers the need for a clinical documentation improvement, or CDI, query.
Imagine you're reviewing a chart, and the provider left a vague progress note stating, "Patient took extra medication." That right there is a prime CDI query opportunity. As a coder, you simply cannot assume intent. Was it an accident? Was it intentional self-harm? You have to clarify the intent with the provider because it fundamentally changes your code selection and your sequencing.
Querying the physician isn't just about being pedantic. It ensures accurate, ethical optimization and prevents severe fraud risks. It prevents unintentional upcoding, which is a massive compliance risk under the False Claims Act. And it also stops undercoding, ensuring the hospital is actually appropriately compensated for the true severity of the patient's illness.
Okay, Section 6, Lesson Summary and Next Teaser. You guys have got this. Let's quickly summarize the key takeaways from today's intensive masterclass.
Always remember, clinical intent dictates your code. Adverse effect means correct use. Poisoning means incorrect use. When it comes to sequencing, poisoning first, adverse effect manifestations first. Don't forget those 7th characters. And relentlessly query vague provider notes to ensure absolute DRG accuracy.
Before we wrap up, I want to leave you with this question to chew on. How do these rigorous sequencing rules shift when we enter the complex world of maternal trimesters and delivery outcomes? Well, next time, in Part 15, we are going to explore the fascinating rules of inpatient obstetrics and maternity coding. It is an incredibly unique section of the guidelines, and you definitely won't want to miss it.
If you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. See you all in Part 15.